volunteering in our program. So I'm just going to talk a little bit about the Community Health Advancement Program. How many folks in the room are from medicine, nursing, or MEDEX PA program? Awesome, thank you. How many are dental? Hi friends, wow, excellent dental representation, well done y'all. So I'm just going to give an introduction to sort of the medicine side of CHAP. I've got my CHAP leaders back here who are going to tell you a little bit about their roles in the program. And then Dr. Cost is going to do the foot care side. And then I believe, and then we have our dental friends who are going to do the oral care. We really do recommend you stay for both because it is important that you know what the other side is doing. We talk a lot about interprofessional care, right? It's important that y'all know what the other folks that are going to be at Teeth and Toes events are doing. So as a brief introduction to CHAP, the Community Health Advancement Program is the oldest service learning program in the School of Medicine. It's been around longer than I've been alive, which means at least 35 years. And we do, our big thing is community-based health equity interventions. And all of our programs come originally from a community needs assessment. Emma and Sangeeta are going to talk a little bit about a needs assessment we're doing right now. And the foot care clinics at the Downtown Emergency Services Center came out of a need from the community where we were seeing a lot of foot problems that were going unaddressed because those weren't important enough for folks to seek care for those issues. So Dr. Cost is going to talk a little bit about the foot exam, but to give folks a bit of an introduction to how CHAP runs, I'm going to introduce Emma and Sangeeta, who are our two lead coordinators right now, and we'll talk about some of the different roles.
Hi everyone, I'm Sangeeta. I'm an MS2 and I'm one of the lead coordinators.
I'm Emma, I'm also an MS2. Thank you all for coming. So we wanted to talk a little bit about the structure of CHAP and encourage everyone to volunteer, and especially tomorrow, or actually we're full tomorrow, but also apply to be a coordinator. So we run foot care every other week, and then we are also doing a needs assessment, if someone wants to talk about that.
Yeah, sure. So yeah, like Emma said, we have like a coordinator team that I think this year we have about 12 people, over 14. We had a pretty big team this year. And so what the coordinators do is at these clinics that we run, you're kind of in charge of running the clinic and getting people who might want foot care, and also just like working with like the logistics and making sure that it runs smoothly. And so that's one role that you can do as a coordinator. And then you can also be involved in our needs assessment that we worked a lot on last year. And so this was because historically CHAP has also done derm clinics, but we were finding that there was some redundancy in services at the shelter that we work at. So we decided to take a pause and do a needs assessment to really evaluate for what like the population, the people who are who are experiencing homelessness, what are their health needs. And so we did this in collaboration with a few other groups. And so we really got the ball rolling kind of last year in terms of starting the needs assessment, but there's still a lot of work left to be done. So if that's something that interests you, then we definitely encourage you to apply to be a coordinator and let Jenya know as well, so that we can get you started working on that. It's a really cool opportunity, and there's a lot of space for you to really decide to make decisions and to kind of figure out like what direction CHAP is going to go in, which is a cool opportunity. So yeah, I think those are the main things that we wanted to say about like the lead coordinator positions. And then along with that, we also have a volunteer coordinator position, a supply coordinator position, and a preceptor coordinator position. And we have two of those people here with us today who are going to talk a little bit about their roles as well.
Hi, I'm Avery. I'm also an MS2, and I'm the supply coordinator, which means basically once a month-ish, I go through all of our mostly medical supplies and make sure all of our medications aren't expired, or if they are, disposing of those, and talking to Jenya and the other staff we have to make sure that things get ordered as needed. It's pretty relaxed. I find it to be a nice break from my other studying things. But I also feel like I'm doing something useful and kind of like back end helping CHAP run smoothly. So I really enjoy it. I recommend doing it. And then I'm also just one of the coordinators that I go to CHAP clinics periodically, like tomorrow.
Okay, now I know how our lecturers feel standing up here because this is very nerve-wracking, and it's also been a long day, so like I won't take any of your blank stares offensively. So I'm Joanna, I'm an MS2, and I'm the preceptor coordinator. I'm also just a regular coordinator as well. And as preceptor coordinator, it's a very easy job. You basically just pester people into agreeing to precept clinics. So if you like details and like scheduling things, which I do, because like the one thing I have control over in my life currently. It's a very enjoyable. It's like you just basically like send out an email at the beginning of the quarter saying, hey, like we have these clinic dates coming up. Is anybody willing or available to precept? People will respond, and then you just send them email reminders like a week ahead of time saying, this is a reminder, like you are precepting this date, and then you also like CC the clinic coordinators for that clinic. So it's very like, it's all online, it's very easy and straightforward. There's already an Excel sheet set up, so yeah, it's very easy, but also very rewarding, and also you should definitely sign up to be a coordinator for CHAP just in general, because it is an amazing experience. I highly recommend it.
So our application closes on October 20th, and we'll send out another reminder to med students, and then we'll get Jenya to send it out to medics and nursing students.
Just on that last point, if folks from medics or nursing are interested in being coordinators, let me know. We have had nursing and medics coordinators in the past, so it is not exclusive to medical students. I think from here, I'm going to introduce Dr. Cost. So Dr. Amanda Cost is a family physician at Harborview and is the faculty advisor for CHAP, and she's going to go through some of the basics of foot care. These slides are available on the CHAP website if folks want to review them later, and also because in order to get you all out of here in a reasonable time, we're going to move through them kind of quickly. So there's time for questions at the end, but we want to make sure we leave enough time for our dental folks to get through their stuff as well.
Hi, everybody. So I'm going to go through this. Has a ton of pictures, just some basic foot problems that you may see when you're doing foot care, and also an approach to examining the foot of someone who has diabetes. So when you are doing foot care, you want to look for any of these foot problems, and it's okay if you don't know what they are right now. I'm going to tell you what they are and show you pictures. And if you ever have any questions, because some of these can be kind of hard to tell apart. For example, corns and plantar warts look kind of similar. Then you can always ask your preceptor for help figuring out what's going on. In addition to when you're caring for the foot, it's also important to look at the leg. That seems kind of obvious, but you might pick up things in the lower extremity that you may not see in the foot. So I always try to have people look at least up to mid-shin or the knee. So before you get started, you want to look very carefully for any signs of infection. When I was a preceptor one night, we actually picked up a case of foot cellulitis, so skin infection, and was able to provide antibiotics and prevent that person from a trip to the emergency room. So if you see any redness, if the skin feels warm, if there's swelling, if you notice anything that looks like pus or exudate, which is kind of this whitish material, if you see any bleeding under the skin or surrounding skin, or if the person reports pain when you're doing any of the foot care, that's a sign of infection, and so you need to let your preceptor know. Foot problems are really hard to heal, and this is because it's kind of like at the very end of your body. They get the most kind of wear and tear in your day-to-day life. Folks that are experiencing homelessness often don't have footwear that is helpful and healthy for them. They may be in situations where their feet are wet or cold or something like that. So if a foot problem is identified, or if there are signs of infection present, we need to definitely let the preceptor know, and then that person may need to go to either their primary care doctor, or possibly, depending on other underlying problems that they have, might need to see a podiatrist. We're going to go through some common ones first. So probably everybody has seen one of these. It's a callus. This is an example of a callus kind of off of the side of one toe due to pressure and kind of repeated friction. They usually occur on bony prominences, This is another example of a callus. This is that kind of the metatarsal head. So usually due to, again, friction within the shoe. This looks, probably some of you have calluses and you're thinking like, why are we so excited about calluses? Calluses are actually a really, really big deal. For people that have diabetes, they can turn into really severe foot ulcers very quickly with very little change to what this looks like. If you see a callus, you need to take extra special care. So you will not be doing the sharp debridement, but this is something that your preceptor could do. The example off to the left is somebody who has cracks and fissures in the buildup of the callus. And then off to the right is after scalpel debridement, you can see that you've gotten down. They haven't even gotten down to the area of skin that would start to bleed yet, but they've removed all of that thickened skin. Here's another example of a debrided callus. And you can actually see that in this case, they're getting down to some of the tissue that's kind of right below the skin. This may have been a debridement that was taken a little bit too far. We probably in our clinic don't want to go this far. Podiatrist experts are able to do this, but for CHAP, please refrain. All right, and then this is an example of a pre-ulcerative callus. So if you look here, that doesn't look all that much different, right, than the picture that we saw before. I'm telling you what can be under this is an infection that spreads all the way, taking up 2/3 of the foot. So what can happen is that within the crack in the callus is that bacteria can work their way under the skin. It can get into the muscle. It can get into the bone. The person can have a bone infection, and this might be the only thing that it looks like on the outside, especially with people that have diabetes and have other sorts of foot problems. So if you see something with a dark spot in the middle, I think that requires extra special caution. That might mean that the infection is getting inside. All right, so now we're moving on to a little bit of a different thing, which is the corn, which is a hyperkeratotic plug, which is a fancy name of something that's really firm, full of skin cells, and is almost in kind of, I view it as like an upside down pyramid. So the picture off to the left, you can kind of see that square shaped thing that's actually pressing into the skin, and they're very painful. The same thing, I think the corn on the other side is a little bit hard to see. It's probably right in the middle where that black dot is. Those are things that are very painful and are pressing into the skin. So people will often come in and not say that the calluses hurt, but this will hurt them because it's pressing into the softer tissue underneath. Here's another picture of a corn that's actually on the toes. And again, if you were to debride this, you could actually lift that whole hyperkeratotic plug out of the surrounding skin. Here's an example of a soft corn. So the other ones, you probably got the sense that if you were to touch them, they would be very firm. This one is soft, and there could be two reasons that it's soft. So one, it could be that the person's foot is wet and it's kind of macerated, meaning that it's soft and squishy. The other thing that could be going on is sometimes what people do to try to treat corns is they will get these things called salicylic acid pads, like or corn or callus pads. They'll put them on, and then it will start to dissolve. It has a lytic effect. It will start to dissolve the keratin. And when you peel it off, you may see the softness there. So it's important to ask people if they've used that. We've got a couple of other pictures. This is a person that has corns basically on every bony prominence of their toes. Again, likely due to trouble with footwear. All right, so now we've talked about corns and calluses. We're gonna move on to common nail problems. So I'm gonna talk about nail overgrowth, fungal infections, and ingrown nails. So you will see nails like this at CHAP. Nail care is very difficult for some of our clients. Either they have mobility impairments that make it hard for them to actually reach down and cut their nails. It could be that they aren't often taking off their shoes. They can't see that this is what their nails look like. Or it could be that they lack the available materials to be able to trim their nails. So you're gonna run into this a lot. We have some extra super strong nail trimmers that you all don't have to use. Your preceptor uses it. In fact, on it, it says for preceptor use only. So you don't get yourself into trouble. Because you actually can, for example, the one on the right is actually probably growing into the skin. If you tried to trim that, there's a possibility that you'll cut into the skin. But you're probably gonna see something like this when you go to CHAP. This is an example of an ingrown nail. What you can see is off to the side, if we were to kind of gently peel the skin off of the left side, kind of away from the nail, you would probably see a little tiny sliver of nail that has actually grown underneath the skin surrounding the nail and is poking up into the side. So do you see how this person has cut their nails in the moon shape? The moon shape is bad. I know it looks cute. do not do it. So we can provide a lot of education on how to prevent ingrown nails. And one of the key take-home points is that don't make your nails look cute. Cut straight across and always make sure that the end goes past where the nail bed is. Because if the end is always past there, then it can't grow up into it. So this person probably left behind a little sliver of nail via their cute nail cut. And then it has grown up in there and they had no idea that it was there. Another thing that we can do to try to treat this, so first of all, this would be an example when you would wear gloves, because this is a person who's having some bleeding, some infection perhaps from the nail. We can try to find that little sliver that's cut up, and we have this stuff called lamb's wool, which is exactly that, it's lamb's wool. And you can make a little wick of it, and you actually put it underneath the part that's growing up in there, and it provides a cushioning bit. So the nail can grow out, the skin around it can heal, and eventually then as the nail grows out, they won't have this problem anymore. This is what's called a pincher nail. So this nail, also probably from cute nail cutting, but this can also just have to do with footwear and other foot mechanics. This nail is actually growing around the tip of the nail bed, and this can be very, very painful. So the person might come in, and I've sometimes seen it grow all the way around such that a little bit of the nail bed is pinched off. If you see this, this is a podiatry situation. This is very difficult for us to address, so you'll need to either refer to their primary care provider to go to a podiatrist or give them information about going to a podiatrist. So those are common nail things that you will see. I'm going to move on to infections. This is what is called onychomycosis, or a fungal nail infection. You will see this frequently. People will desperately want this to get better, and they will ask you for a cream, and the answer is, sadly, there is no cream that fixes this problem. There are some topical things that people put on their nails sometimes. Works a little bit better with children, but even the pharmaceutical grade products have a cure rate of like less than 10%. So don't be tempted to give out like tubes and tubes of clotrimazole thinking you're going to fix this problem, because you can put clotrimazole on this forever and it will never get better. And the reason is because the infection is actually in the nail matrix, which is below the cuticle, and they can't get the medicine to go in there. So if you see this, what we can do is provide with the materials that you have in your foot kit. We have a pumice bar. You can do, once it's built, you can do some debridement, some kind of scraping of the thickened nail to make it more comfortable. And then we can also, you can ask your preceptor to use the preceptor clippers to cut it down. People will often, again, if they ask you how to treat it, you can tell them that you need to take about 12 weeks of medication to make this better. Doesn't work all the time, works maybe like 60% of the time. There are many treatment failures, and oftentimes people will get reinfected. It also has the potential to cause liver failures. So I usually recommend, this is a cosmetic problem, not a life-threatening problem. So unless people have real indications to do it, I usually try to have people just kind of grow to learn, or learn to love their thickened nails. But providing some nail debridement and filing down is definitely very helpful for people. All right, so this is a plantar wart. Looks pretty similar to the callus we saw before, right? Like, I'd be hard pressed to necessarily identify the clear difference between the wart versus the callus. But if you were to kind of pare it down, and this one has, again, had a little bit of debridement, or if you look really carefully, what you will see is that there are small punctate spots of blood at the base of this, and this is happens due to the virus that's causing the wart. So if you see this, this is a wart, and then you can tell people we actually have wart treatment available to you, and you can provide the wart treatment pads for people. This is a better, closer up picture. So do you see how it looks kind of like the architecture is distorted, this kind of whorly pattern, and then all of those spots of blood is kind of like one little capillary that's changed by the virus. You will not see this with a callus. This is kind of the distinguishing features. Moving on, probably everyone has experience with this. Tinea pedis, or athlete's foot, often in areas that are in dark, warm, wet places where the fungus likes to grow. We, again, have clotrimazole and other topical meds to try to treat this. The other thing that you can do is provide people with fresh socks. That's one thing that's going to be really helpful, is if people have a couple of changes of socks that they can launder so they're not constantly kind of reinfecting themselves. And then we actually have some foot powder that's available too that helps kind of dry out a wet situation. Oftentimes you'll see it between the toes. So I encourage you to spread each pair of toes and look carefully in between, because sometimes it can be quite subtle and just in the middle. And you might think to yourself, like, who cares about a little case of athlete's foot? People with diabetes can get their foot amputated because they have athlete's foot. This is a place where infection can easily get in, and if it gets in and causes a deeper foot infection, then they could possibly require a foot amputation. I've also seen people where the cracks from the tinea allowed for a bloodstream infection. So we want to try to treat this if possible. This is a more kind of extensive case. So you might see somebody where the entire foot is covered in this. When I was in medical school, I learned to look for, almost like if you're wearing kind of flat shoes like I am, something that would cover the whole bottom of the foot and start to creep around the top. So kind of, if you think about somebody wearing a pair of flats, that might be the distribution that you would see it in. The other thing that you might often see is I also look at people's hands. It's sometimes 2 hands and 1 foot, or 2 feet and 1 hand. And sometimes it's because the person is scratching or touching their feet and then their hand gets infected. But I would take a look at their hand to make sure that that's not an area where they may be reinfecting themselves. This is an example of the tinea almost causing a lytic reaction where the layers of skin have slipped off and there's some redness and a little bit of irritation underneath. This is an example of it being, this again, you might look at this and think, does this person have cellulitis? Is this a skin infection? This is actually just irritation and redness from the tinea. This is someone who definitely needs medicine. In this case, if it was that extensive, I might consider giving people an oral course of antifungals, and you can talk to your preceptor about that. The benefit of that is that you don't have to take it for 12 weeks. Usually you have to take it for 2 weeks, and you can really clear things up more quickly. All right, so that kind of covers basic foot infections. You can see there too, this person probably, even if you treat it with a cream, they have onychomycosis, and so the infection is going to stay in their body unless they take oral medications and clear off the nail infection. And so this is a person who is probably going to continually reinfect themselves unless they practice, like really, really careful foot care and are able to do that, or unless they constantly apply antifungal cream. So I have a patient who has nails. He's very diligent about his feet. Poor guy, just like always has foot infections. And I'm like, you know what? Just keep refilling the clotrimazole. He's like, I use it, it gets better. Then I stop and it gets worse. And I'm like, it's always going to happen. Just continue using it. Take a break when you get tired of putting it on. Then when the rash comes back, put it back on. So oftentimes people need long-term treatment. All right, I'm going to move on to some bony deformities that you might see in the foot. And this is something to be on the lookout to see, because we'll often see calluses and corns form as a result. So this is what is known as a bunion. You can kind of probably see that the great toe looks like it's pointed more laterally than it should be. And oftentimes that first metatarsal is an area where there's irritation or a pressure point. This is what it can look like from the other side. You can almost see that the other smaller toes are squished because of the bunion deformity, and some calluses forming there on the side. Sometimes people can get infection in their bunion, or they can get osteoarthritis there, and it can be quite painful. And so if you see this, I would probably make sure to tell your preceptor to examine it to make sure that, is this a kind of localized skin infection, or is this just irritation, arthritis from the bunion going on? And here is kind of a picture of what's happening to the bones when someone has a bunion. The other thing you might see is something called a hammer toe. So this is where usually not the great toe, but the smaller toes will form kind of an L shape. And this can be due to neurological problems or due to footwear and kind of chronic changes in foot mechanics. But this is another place you can probably see the top of that toe as an area that might be a pressure point. Here's another picture of someone that has a couple of hammer toes. All right, I'm gonna move on to leg problems and discuss a couple things that you might see in people's legs. So this is a really, really common problem that you will see. This is called venous stasis, which basically just means that the veins in the legs are not working well enough to get the lymphatic fluid and all the other fluid that collects in the legs out of the body. And so you'll see a couple of different things. One is that if you pressed on this, this person would have pitting edema. Two, you see kind of the brownish discoloration. That's hemosiderin deposition that happens from little tiny red blood cells coming out of the blood vessels due to the increased pressure. And the third thing that's happening is this person has actually developed an ulcer. So that can happen because there's rubbing against that area. The tissue is quite swollen, so it's thinner. Sometimes people will have a blister that then opens up and then becomes an ulcer. So if you see this, this is a serious problem and we need to get this person into care. If someone who is experiencing homelessness gets this can take years to heal and requires, like at Harborview, we sometimes see people 2 to 3 times a week to provide wound care to get a wound like this to heal. This is another example of venous stasis. So you can see that this person's legs look a little bit red, and that's not because they're infected, but that's because of the irritation from the edema in the legs. So this is why it's important. Like if you just look at this person's feet, you might be like, oh, not so bad, right? But if you look higher up, you can see that this person actually does have quite a bit of edema. We used to have compression stockings to help with this. You actually can't give people with diabetes compression stockings unless you know kind of how well their arterial blood supply is into their foot. So we don't typically do that. If people, this is quite painful. We do have ACE bandages if you want to provide people some support. That can often help reduce some of the swelling. All right, so I'm gonna finish up talking a little bit more about diabetes and how it impacts people's feet. So there are a lot of things that have to interact to help somebody have healthy feet. So this is kind of a very complicated model that indicates like why do some people get foot ulcers and why do some people not? And some of it has to do with the social determinants of health, like where is the person living, what kind of education, employment do they have, what other kinds of psychological things are going on, how does their identity impact those social determinants of health? And then the other things that have to do with whether or not someone gets a foot ulcer is, so what is their knowledge in their own self-care behaviors, right? How are they able to adhere to their medications, monitor their glucose, do things that help manage their diabetes? How is their access of care? Do they even have someone who's trying to manage their diabetes? Do they like their doctor? If they don't like their doctor, they're less likely to go back, and then that makes them more likely to have a problem with their feet. And then are we doing the things that we need to do? So everybody that has diabetes should have a foot examination yearly to check for neuropathy, and then if they have neuropathy, should receive diabetic footwear. All right, so all of these systems help support a healthy foot, and if they are impacted by diabetes, it will also lead to a diabetic foot ulcer. So I talked a little bit about this before. The first is usually what happens is that there's plantar pressure, so pressure or friction along the bottom of the foot. You'll get a callus formation, and underneath the callus will be tissue damage via that crack that will cause an infection in the softer tissues and then go on to develop osteomyelitis and infection in the bone. And so then the osteomyelitis is really the end stage of the diabetic foot ulcer, and we are trying to prevent that because once you have an infection in your bone, it is very, very, very difficult to treat. So kind of the way that we talked about those different systems, kind of the way that they work to result in an ulcer is that, first of all, there's changes in the way that people feel their feet, and so they have reduced pain sensation. The neuropathy from diabetes can also be motor, so they get an abnormal foot posture, so they might develop bunions, those hammer toes. In an extreme case, they might get something called a Charcot foot. And this causes different loading on the bottom of the foot, causing callus and ulceration. At the same time, they have arterial disease. They're not getting quite as much blood to their foot. And so they have relatively low oxygen to that area. And then trauma because of the fact they can't feel their feet makes it more likely to have ulceration that causes an infection. And then once someone has an infection, they don't have quite as good of an immune response, and then it's difficult to clear up the infection. So this is just kind of things that you might do as part of a foot exam to include diabetes. So we always look at the general appearance of the foot and look for pressure points and calluses at those areas. You look to see, do they have any ulcers present? Do they have any signs of cardiovascular changes? So this is when I said that like looking at the leg might be helpful. Oftentimes people that have trouble getting blood flow, arterial blood flow to their lower limbs will have loss of hair. So you'll look and they have like 0 leg hairs. And you're thinking, oh, this person is just very fastidious about shaving. The answer is no, they've actually all fallen out because they aren't getting enough blood supply. The skin will also be thin too. And then you might notice when you do your neurological exam, we'll talk about the foot exam, that they can't feel the diabetic foot kind of light monofilament. You can also do light touch or temperature. I generally don't do pinprick because I don't want to put any hole in anybody's foot that has diabetes as a potential option for infection. So this is a pair of good shoes. This is probably a pair of diabetic shoes. You can probably guess that some people that are very fashion conscious may not want to wear this shoe. So there actually are more options for diabetic footwear that is a little bit better, but I've had patients that say that they don't like their shoe because it's ugly. So I try to encourage them to talk to the person that's fitting their shoe to get a shoe that they will like. So this next slide goes through what happens to somebody who had diabetes and got an ulcer. It takes it over a course of a couple months. So this was all the way back in 1988. This person came in and this is what they had. Kind of it looked like a little abrasion or an ulcer there. So this is in March. 2 months later, the infection had spread. It's involving the nail. There's this kind of necrotic eschar on it. After 2 months, again, largely due to probably infection and arterial problems. And then this person's foot, a year later, actually amputated itself. So the toe, this person lost the toe by themselves. So this is why this back here didn't look like such a big deal, right? But it can end up like this. So it's really important to be aware of what people's feet look like. And if you see something like this, to talk to your preceptor so we can make sure that we get the patients into the care that they need. All right, and then I think you all are going to go through the basic foot care slides, correct? Okay, that's great. Any questions? I know that was a ton of pictures, including maybe ones you didn't want to see after eating pizza. But any questions about these basic things? I would encourage you to look through the slides again, just to familiarize yourself with the pictures. And then if you see something and you don't know what it is, it can take a long time to look at skin findings and figure out what they are. So certainly ask your preceptor for help.
Yeah, thanks. All right. So I'm just going to very quickly go through sort of what's in our kits. So basically in our foot care, this is not like sophisticated high-level wound care, right? We are not amputating toes. Do not try and amputate anyone's toe. Okay, in case that needs to be said. So basically what we're doing is we're washing feet, we're soaking feet, and we're cutting nails, and doing a little bit of sort of foot hygiene. So normal healthy nails, as Dr. Koss said, some of those more like longer, thicker, mangled nails. We do have sort of surgical steel, heavy duty nail clippers. We sterilize them between clinics so that you always have fresh sterile pairs going into clinic. They should really start with the preceptor. And then we do not do debridement of calluses and corns with scalpels. There's no scalpels in the foot care kits. So foot hygiene is really more what we're doing. So how many people know that you're supposed to cut your nails after you've bathed? Because your nails are softer because they've been in water? Yeah. So cleaning the foot, a little bit of, folks are like, oh, I just learned something that I can take home for myself. True story. True story. It is easiest to trim your own nails after they've been like in a warm bath or a shower. So we do have, in every foot care kit, so we have a tub and there's one of these ultra absorbent pads. And one of the things that's really important about the actual physical setup of our foot care clinics is that the student is actually sitting below the patient, right? So there's we're trying to challenge that power dynamic a little bit. So the medical student, nursing student, PA student who's doing the foot care will actually be seated below the patient. You'll have a basin that you'll fill with warm water, and you will add this delightful, soothing oatmeal bath, which again helps to sort of soften the skin, soften some of those rough areas. It's really important that before you do anything like cutting or scrubbing, every foot care kit includes something called a monofilament, which is just a very simple little, I don't know if you can even see this, but there's a little piece sticking up here.
and you use that, there's a little guide on the back to poke certain areas on the ball of the foot to try to determine whether this person has loss of sensation in their feet, potentially from something like diabetic neuropathy. You don't ever want to do something to the person's foot before you've figured out whether they can feel this little touch. Because if they do have loss of sensation, then we should not be debriding anything off their feet because they can't feel it, right? Has anybody here ever gotten a pedicure when they scrub the bottom of your feet and it's like, feels good, but it's also kind of excruciating and like really tickly? Imagine if you couldn't feel that, right? So we don't ever want to be scrubbing anything off of a foot that can't feel that sensation. But if you've done that test, then all of the foot kits include a pumice stone, so you can scrub some of that rough skin off the feet. This also includes soap. It includes a mirror, so you can teach folks how to look at the bottom of their feet to check, right? Especially for folks that have diabetes. If they tell you they have diabetes, there's a little hand mirror in here, so you can teach them how to look at the bottom of their feet if for whatever reason they have trouble seeing the bottom of their feet. Not everyone's that flexible. We also include moisturizer and soap in here, a nail file, nail clippers, and a cuticle pusher. And at the end of the foot care exam, the patient actually gets to take this home with them. So you've now showed them how to use everything, and if they want to, they can take this with them. Once this stuff has been used, we don't use it again. So if the patient doesn't want to take it, that's fine, but we get rid of it, right? So we can preserve the sort of sterile nature of the kit. So you can apply some of that lotion and show folks how to apply the lotion. Again, like Dr. Koss said, make sure you apply between the toes. And then washing the feet, right? So we have some mild soap in here. Yes, don't scald people, please. That's uncomfortable. Nobody wants that. It's really important to help folks dry their feet. So these pads are super absorbent. You can use these to help dry the feet, especially between the toes. And then as Dr. Koss said, we have, there's a medication box that the coordinators will bring to every clinic. We are the only diagnose and treat clinic in the School of Medicine. So we provide all of our own medications and bring them with us to clinic because folks identified pretty early on that like, if we can't treat the thing we're seeing them for, we're not actually that useful to them, right? And so we give a lot of people permethrin for their scabies. We give out a lot of antifungals and antibiotics for infections. So we also have some of that powder that Dr. Koss was talking about, the like Gold Bond medicated absorbent powder. So if folks are having trouble keeping their feet dry, and by the way, coming up on the wet times of the year, the demand for foot care definitely goes up and the severity of the stuff you're seeing definitely goes up, because if you can't put on a clean pair of socks every day, it is really hard to keep your feet healthy, right? So I'm helping folks keep their feet dry and warm. DESC, where we do these clinics, does have they have some clothing donations available. So if you see somebody with footwear that you're really concerned about, bring that to the attention of the staff and say, hey, is there any way to get this person a better pair of shoes? We're happy to give them a couple pairs of socks, but really, you know, if their shoes are full of holes or if they're wearing flip-flops in December, like all of our efforts aren't gonna really get us where we're trying to go. So helping folks understand the importance of keeping their feet dry. And to the point that Dr. Koss was making about some of that edema, it's also important to ask people how much time they spend on their feet, right? A lot of folks who are experiencing homelessness don't have a place where they can just sit during the day, right? A lot of us think about how much we sit during the day and go, oh, right? Like I'm at my computer all day, or I'm in a classroom all day, right? Imagine what it would be like if you could never really sit down anywhere because it was literally criminalized, right? We call it loitering, right? So think about how much people are on their feet during the day and how much that affects their foot health. So we do provide the moisturizer in here to help folks keep, you know, to talk to folks about if their feet are really dry, especially again in the winter. Sometimes you get that dry, cracked feet. We've all been there. Trimming toenails, basic hygiene necessity. Again, if you see a nail that looks unhealthy, abnormal, infected, don't trim it. Call your preceptor over and ask for help. Again, don't go for the cute curved nails. Cut straight across. So here's an example of a properly cut toenail where it's sort of cut across the top. And this is an example of an extreme example, admittedly, of a badly cut toenail. Checking for foot problems. Take your time. Talk to the patient about if anything you're doing is hurting them, right? Make sure that if they say, ow, you stop and check in. Make sure you know what's going on. and make sure you sort of get as much of a view of the foot as you can. That's sort of the intro to foot care. So this tub, we like to say if you use everything in this bag, you'll be fine. And then every foot kit, when we do this, has a laminated sheet with the steps to foot care, so that if you need a friendly reminder, there's a waterproof copy that you can just set down next to the basin so you can remember your steps. Don't ever be afraid to ask for help. If you're worried that something might hurt somebody, pause and call your preceptor over to get a little bit of help before you move forward with it. So I know we went a little over our time. I want to make sure there's plenty of time for dental folks, but I'm going to hang out. So if folks have questions about foot care, the clinics, how it works, how does CHAP work, I'm happy to hang out and answer those questions. And if you're not too grossed out, please eat more pizza. All right, are we switching over to a different slideshow? All right, thank you all for listening. Please feel free to check out our little sample foot kit. All right.
You're fine. Okay. No, you're good.
I was starting. No, I don't have those.
Just four slides.
I would bring that. They're great shape.
Should you start? Should we start? Okay. All right. So we're just gonna go ahead and get started. All right. So we're the dental side of Teeth and Toes, and we're currently the clinic leads. I'm the D3. I'm Isaac.
I'm Jackie. I'm a D2.
I'm Nusha. I'm a D3.
All right. So let's get started.
So our faculty advisor is Dr. Gandara, who's right over there. And Chelsea Stone is the OEPD who runs pretty much all of our site coordination, all the paperwork that we need filled out for all the treatment and events that we do. Are the AmeriCorps? Okay. So we have 3 volunteers from AmeriCorps that come help us out as well with all the paperwork and help Chelsea. And then we're the student leads. So there are 2 different sites that we usually go to. One is Chief Seattle Club, which is where we usually do the Teeth and Toes together. And then the other place we go to is Mary's Place down in Burien, and we'll usually do treatments there. So we'll set up a mobile clinic. And so these are just some of the pictures from the different things we've done. I think the main thing is the picture in the upper right is where we set up the mobile clinic in Mary's Place in Burien. And so we have a bunch of 3 sets of portable equipment that we can bring and set up at this shelter and provide care on site for the people that are there. And then another cool thing is when we're at Chief Seattle Club and we have the med students and nursing students doing the toes part, we can go over and observe their toes and the things that they do on that side, and then they come over and watch head and neck exams or anything, and we can learn different things.
So some of the services we provide on the dental side is oral health education and instruction, like brushing and flossing. We also provide examinations and fluoride application, just as a preventative measure for caries or patients with high caries risk. We also have hygiene kits, and those usually have toothbrushes, toothpaste, floss, and we have specific ones for pediatric patients as well. We also do consultations and referrals, especially if we have a longer treatment plan and they need to be followed up. We'll have them referred to one of our partner clinics, so NeighborCare, CMAR, or the Seattle Indian Health Board. So in terms of oral hygiene education, I think the most important aspect of this is plaque control, and just with the hope of controlling disease, the most common being caries, gingivitis, and periodontitis. And knowing the normal anatomical structures is really important for the patients to know, so that they know if they have disease, and they can just know whether they have healthy oral hygiene or not. Because a lot of patients you'll see will come and say their gums are always bleeding when they brush, and they think that's normal just because that's what they've had their entire life. but just explaining that to them that there actually is a disease process why that's happening and trying to talk them through that. And also nutrition and how frequency of consumption matters as well. In terms of oral hygiene education, we like to talk about proper technique for brushing and flossing. I think one thing that's interesting about this is the technique for a manual toothbrush and an electric toothbrush is actually different. Maybe that's something that you guys are learning here today. For a manual toothbrush, you typically want to go 45-degree angle and back and forth small strokes between 2 and 3 teeth. But for electric toothbrushes, you typically want to hold it in a spot and move it down the line as opposed to making any brushing motions. And that's to prevent any trauma to your gingiva. And also just the technique for flossing. You'd be surprised, a lot of patients actually don't know how to floss. Last week I had a patient, an 86-year-old patient actually, who had a piece of pepper like stuck in between her teeth in the front, and she didn't know how to get it out. And she was really frustrated because her entire life she would just use toothpaste because that's what she was used to. And so she asked me if I could remove it, and I was like, you know how to floss? I can teach you how to do that. And she's like, I never learned how to do that. So I taught her. She's super happy. So at this time, we're gonna do a demo for head and neck, and Noosh is actually gonna do this on Jackie. And we wanna do it probably somewhere in this center aisle. So if you guys can't see, just move around, just get close to them. It's gonna be a lot easier to see.
So normally we wear a mask too, and I wear protection, so that's gonna be, but we're just gonna go with it today. Okay, so normally when you're doing a head and neck, we're just going to start with the patient. As soon as they walk in, you're just gonna take a look, look at the way they walk and how they carry themselves, see if there's any motor impairments or if they're having trouble walking. We can usually just note that. And then the patient's sitting down, so you're just gonna take a look. You're gonna look at her face, look for symmetry, or asymmetry. We're just gonna like look at her for facial features. We're gonna look at her scalp. We're gonna look at like the amount of hair, if she has any like receding hairline, or if she has any like malformations. We're just gonna note that. Okay, then we're gonna start palpating areas. And so people have different ways to do it. I normally like to start with the sinuses. So we have like a frontal sinus here. So I'm just gonna like palpate this area, and I'm gonna ask her if she has any pain or tenderness. And she'll let me know. And then do the same thing for her macular sinus here. And then we can also just do like bony landmarks. I don't know how much we're going to get to, but so we'll do like supraorbital, infraorbital, and I'm just like palpating. Patients usually say it feels like a massage, so if you're pressing too hard and they're feeling pain, just coordinate with the patient and make sure you're pressing that. And then for like dental stuff, I'll usually go to the back, and then we'll look at like the mandible and just going through here, like the bony area, and then also like the actual mandible bone and feeling for anything. And then so the submandibular glands and then the submental glands are here and then back here. So I'm gonna palpate this area and then go around. And then I'm gonna palpate the carotid gland here. And then the tail is at the bottom, so we'll make sure that you're also doing the tail. Up in there, do it on top. bilateral palpate, see if I notice any, like, so you're looking for hard lumps or things that are immovable, but and then you can also feel the lymph like temporal and like temporal, so you can feel those too. And then we palpate like the supraclavicular zone that makes you ask the patient if it's you the combo or not. So we will palpate for you too. And then we'll do the dental stuff. So for the dental stuff, I'm just gonna have her open and I'm gonna look to see that when she's opening and closing, if there's any like asymmetry, like if she's something to one side versus the other as she opens and closes. And then we'll also like go ahead and open really wide. We're gonna just measure like, so normally we put like 2 fingers here, but I don't know. Put my fingers in now. So we're gonna measure like how much her mouth is open, and if she has like limited opening, we're gonna note that. And then we're gonna have her so do like go to the left, shift your jaw to the left, and then shift your jaw to the right, and then bring your jaw forward. And then so those are all like we're doing range of motion with her mental. And then we can also do like range of motion with her neck if you wanna bring your neck to your clavicle, and then to your right and to your left, and then so back. Another thing is the TMJ joint, so that's really important. So I'm gonna have her open and close, and so you can listen to the opening and closing. If there's noise, or if you feel like popping, you can also note all of that down. And then you can also feel, so the condyle will shift forward as she opens and closes, will shift back. So you feel like instead of like smooth motion, it's kind of feeding to the side. That's also something to look out for. There's muscles of mastication, so normally I'll have her open and clench this part. So I'm palpating this area of the master, and then do the same thing, open. And then so like the temporalis, I'm just going to palpate this area. And so when she opens and closes, this muscle will pull back, so you want to feel that and don't feel anything like that. So to feel her thyroid, if it's a normal thyroid, you're not going to be able to feel anything, but I'm going to have her swallow, and then I should feel the cartilage moving up and down, swallow. So you can look for that.
Yeah, I think another thing is Nusha is an amazing student. So she did super thorough. So don't be super nervous about memorizing everything. I think when you're out there, seeing patients, a lot of times you'll kind of do the main things, and then if there's anything that looks suspicious, you'll check that out. And then also all the dental students get tested on this. And so for any of the nursing, medical, and med-ed students, if you guys want to try a head and neck exam, you should just try and ask a dental student to do it with you, and it'd be a really good experience. Yeah, but you hit everything.
So like we normally do this for patients exam or the procedure. So it's really hard to feel something as normal when you normally feel like everything is normal. So it's totally fine if you're suspicious and you just want to again, that they're like sending the and it's always fine. Like it's better to be on the safe side if you think something suspicious and have an type of like it's totally fine, then be like, oh, this is probably okay, this is still normal, and then it's just out. Isaac will talk more about the teeth, but I thought it would be helpful to just tell you like what the teeth numbering is. So we'll start with the upper right, and that's your tooth number 1. And then we're going to go like right to left on the top, and it's just gonna go 1 to 16. And then your bottom left is gonna be 17, and it's gonna go to your bottom right and that's 32. So you just count from like upper right to left, and then your left to right. You'll have your seat numbers, and then I just will tell you what.
Awesome. Yeah, 1, 16, 17, and 32 are listen to. So I guess in terms of when you do the intro oral exam, there's just a couple common, I guess, diseases that we would like you guys to watch out for. So gingivitis is very common. It's inflammation of the gingiva. It's often red and swollen. Actually, a lot of people in this room, including myself, most likely have some form of it. Periodontitis is an infection, so it's much more involved. That spreads down to the bone and it's irreversible. So at this point, it can only be managed. And so at that point, you would want to encourage your patient to go to regular cleanings with a dental professional. We also check for the tongue. Specifically, we're looking for signs of oral squamous cell carcinoma because it's the most common malignant neoplasm in the mouth. And early detection is key because since the discovery of this disease, the prognosis has not gotten better. And this slide is to show kind of different, I guess, etiologies of dental caries, because a lot of people, when they think of cavities, they think of a black lesion. But all these pictures are examples of caries. And oftentimes you can detect them through surface changes or discoloring, and sometimes they won't be as obvious as the patient on the top right. And so just watch out for that. And then just to finish off our presentation, we want to talk about fluoride because that's actually a treatment that we provide for a lot of the patients at our outreach clinics. Fluoride is very safe and effective. The fluoride concentration in these varnishes are actually, I think, 5 times more than what's found in your toothpaste. It does not take a lot of time, and we don't need to get into all the chemistry, but it pretty much provides a remineralization process in order for your enamel to stand a chance against any bacterial, I guess, the caries process. So I guess Nusha can give another demo for fluoride varnish.
Okay, so I just show how to do the fluoride varnish on a couple of different teeth. And in teeth and post, we can have med students in the conversation. So the most important thing, it'll come into, it comes in this kind of like tube container. The varnish is here and it's like a brush. So the most important thing is make sure that the patient teeth are nice and dry. Because the water will destroy the fluoride. Okay, so there's a little product we're just gonna like mix the varnish, then okay, so we're just gonna put it on the tube, and then the only thing is be careful, like we're just gonna put it on. I'm doing it slow, but normally like go like in one kind of thing, like a brush stroke. The only thing is to watch out for the soft tissue, like down the lip, because this can be like irritating or if it's soft tissue, and then open the side. And then you can also put it on the like on the side. Yeah. Okay, so just go on the like start from the circle and go. And you can apply just a little bit on the Google surface, but it will get worn away so you won't push it. And then open wide. And then you can do it on the wall.
Awesome. And then in terms of post-fluoride varnish instructions, just instruct your patients to not eat or drink for the next 30 minutes. And a lot of them will want to rinse their mouth with water because the varnish is very sticky and it feels like you have like taffy stuck on your teeth, and it's going to feel like that until they either brush it off or start eating. And they don't need to brush their teeth that night. And a lot of patients are happy about that.
You have Jackie. How does it feel to have it on your teeth? Can you just tell them so they?
I don't know. It's just like a weird kind of gel. It kind of feels like it's coating your teeth, so it just feels kind of weird for a little bit.
First hand.
All right, that's our. Okay.
I just want to make a comment, right? I think we stressed out about the radiology is that there is a strong, and so if you see an out of control periodontal, it may be that and periodontal disease is really exacerbated actually makes it hard. So it's kind of part of managing diabetes, good oral health. That's why we look at the teeth and toes, those kind of make an impact.
I think there was a question.
Question?
Oh.
Oh, okay. All right, thank you.
Did you have a question?
Like more general stuff. Yeah. Yeah. For CHAP or for the dental side? So for CHAP, our application for coordinators is open now. Emma is going to resend out the link to med students. If you are a nursing or PA student who's interested in a coordinator role, let me know. And then there's just a quick online Catalyst survey, and then our goal is to turn over leadership from the second years to the first years in early November. And then once you've taken this training, you can start volunteering at CHAP clinics. There's a We Join In that Emma, generally the volunteer coordinator, we've had the same volunteer coordinator for 3 years. She's about to graduate in May, so we're handing that role off this year. But Haley sends out emails with a We Join In where you can sign up to volunteer in clinics. But if you're having trouble finding that, don't hesitate to get in touch with me. I'm happy to connect you to sign up for those clinics. So now that you have done this training, you're welcome to volunteer in clinics, but you're also welcome to sign up as a shadow if you want to shadow a current coordinator to sort of learn the ropes of how the coordinating piece works. And I'm always happy to talk folks through, like we have a whole policy and procedure manual, and we've been around a long time, and so a lot of our stuff is written down, so I'm always happy to walk folks through those pieces as well. But yeah. So y'all, if you want to sit down and walk through the procedure manual with me, we can do that walk. Yeah. So that's a great question. So this training session only happens once a year. For us, I'm not sure if the dental school offers training in just the once. We have actually uploaded those foot care slides and some other materials to our website. So if somebody you're talking to is like, oh man, I couldn't go to the CHAP training, let them know that they can review those materials online and then just contact me and we can still add them to the list of folks. Oh, that just started a whole bunch of questions. Yeah. The CHAP clinics, the foot care clinics we do every other week are at the Downtown Emergency Services Center, which is the largest emergency shelter in Seattle. It's in Pioneer Square, right across, it's on like 3rd and James, right across from the courthouse. So usually students either drive their own cars or they use a U-Car and they take the supplies down to clinic, but you can also take the light rail. It's super close. And our clinics are on Wednesday evenings. So if your PCP, for example, is downtown, super easy to just pop over to the clinic. And then the Teeth and Toes events we do at Chief Seattle Club, which is a day center for Indigenous folks who live in the city of Seattle. They offer all kinds of both hygiene and counseling and job training and all kinds of amazing resources. And then Mary's Place is a women and children's shelter in Burien. So that's where we do the Teeth and Toes events. We usually do those on holidays because they're open even though school is closed. Yeah.
we'll be doing after we or no?
That's a really good question. So if you want to talk about liability and the lawyers, we can talk about that too. The short answer is that foot care is not considered the intractable practice of medicine because we're not doing anything we can't take back, right? So like if you give someone an injection, you can't take it back, that's considered the practice of medicine. This is not. So you are covered for liability by virtue of being a medical student at the University of Washington. That's why we have a preceptor. So if there's something that a med student should not be doing, then that's why we have a preceptor there to supervise it and perhaps do whatever is like a step above what students can do. But for our dermatology clinics where we were doing a more diagnostic and treatment, we did make a soap note on every patient. So we do also keep a drug log. So any medication that comes out of our box, we keep a log of it because we are giving out prescriptions also. And so we want to be thoughtful and responsible so that if, for example, we get a call that there's been a recall of permethrin, we need to know exactly who how we've given permethrin to, because just because these folks are experiencing homelessness does not mean that they don't deserve the best care we have to offer. And so we try to adhere to that very high level of documentation so that we can be accountable to the folks we serve. Yeah. Was there another question over here somewhere? Yeah. That's a great question. The foot care clinics are usually about 3 hours. So students will usually leave campus 5:30, 5:40, get down to DESC around 6, and then they take their last patient at 8:30. Any other questions? That exam with the dental, that was really impressive. I had no idea. That was awesome, yeah. That's a great question. We encourage folks to, it's PCP day for half of our medical students, which means they've been in a clinic all day. So they're wearing like business casual or maybe even a step up from that. Folks are welcome to come in scrubs. We just encourage you either wear scrubs or wear something professional. So we don't recommend like long neckties because they're disgusting. Seriously, neckties are disgusting. Don't read the studies, but they're disgusting because nobody ever washes them. Yeah, yeah. Bow ties acceptable and very cute. Don't wear long ties. And then we caution. And then, for example, being cautious about wearing low cut tops, partly just because you're sitting below the patient, and so thinking about sort of what is appropriate clinical dress for you. But yeah, scrubs are totally fine. Yes. We prefer that folks be able to stay for the full time, but if we have enough volunteers that it's okay for you to leave early, that would just be something to communicate to the coordinator so they know to expect if you can't stay the whole time. Like if you're the only one and then you have to leave early, we can't serve folks. But if there's 3 volunteers that night, it's probably fine. Just let them know. Yes, so the coordinators for the evening are responsible for transporting the supplies. So the coordinators are responsible for either driving their own cars or getting a U-car. We pay for those things, by the way. So if you do have a car and you drive it and you have to pay for parking or anything, we cover those costs for you. So we don't ever want volunteering a CHAP to cost you money. So we're happy to pay for a U-car if you need one, or to reimburse you for parking if you ever have to pay for it. But it's the responsibility of the coordinators to make sure the supplies get to them. Okay, please take some pizza on your way out. Thank you all so much for coming.
I just need to make an announcement for the dental students. If you signed in, these hours count for health and homelessness, so make sure you sign in to get your hours. Thank you.
Do you want to take the sign-up sheets? Do you want me to take the sign-up sheets? I'm just gonna scan them for my purposes. Perfect. But do you want me to scan them and send them to you? Sure.
That'd be great. Yes, yeah. And those are our pins, so I'll just grab them.
What you're doing is what I'm doing.